All right, so I will be moderating today's talk about WAHA around the world. So I want to introduce our panelists first. We have William, who is from Toronto, Canada, Imola, who is from Hungary, Irina, who is from New York, and then Dr. Punch, who you're representing a couple different countries, aren't you?
I will be sharing some perspectives from a hematologist colleague in Nigeria, as well as another pediatric hematologist who deals with inborn errors of immunity from India, who trained here.
Okay. So, as most of you know, healthcare is administered differently in different countries. So, to add context to what they're going to be sharing, I want to ask you all just extremely briefly describe how healthcare is administered in your country. For example, socialized medicine, third-party payer, etc.
Okay. In Canada, we have a bit of a socialistic healthcare system. So how it works in Canada is you usually go to your general practitioner or family doctor. Then he would, using his vast amounts of knowledge, would determine which specialist you need to see, depending on what symptoms you're experiencing. But in a lot of cases, and especially in my case, what ended up happening is I became very jaundiced when I developed WAHA. And what happened was I still needed to go see my GP. First look he gave me is like, you look very jaundiced. You have to go to the ER immediately. So at that time, I went to the ER. Thankfully, the hematologist there, when he did the CBC, he was able to determine that I was likely having an autoimmune disorder of my blood. So thankfully, I got treatment immediately with prednisone, and 2 years later, I'm still kind of battling this disease. But that's how it works in Canada. I didn't pay a single cent, except for some medication. Even rituximab, my insurance company, I work for a company, provides coverage for that. But normally, you would in Canada, Rituxan needs to be paid out of pocket if people don't have insurance. So it's kind of a socialist and kind of a capitalist system in Canada.
I have a question.
Sure.
How long did it take you to get rituximab?
Oh, that was a journey. It took a few months, and it just the insurance companies would nitpick on very little details, and they kept on sending the application back to me. I went to my doctor again, and back and forth. It took several months before I got rituximab, when it was one of the first treatments that my doctor recommended taking. Yeah.
Okay, so I'm from Hungary, which is a little country in the heart of Europe. The healthcare system is pretty much similar to as what you described in Canada. So we have a public healthcare system, meaning that everyone is entitled to free healthcare if they have an official employment and they pay taxes. Due to political reasons, the healthcare system is not in a good shape at the moment, which means that most of the people in the country who have any kind of condition or disease need to turn to private doctors, which can be really frustrating, because there you don't have the security that you will always have the same doctor at the same doctor available for you. So it can be pretty harsh there. But if you have any life-threatening conditions, like for example, as you mentioned, you needed to go to the ER, that was the same for me. The ER part is okay, so we get handled there. But from that point on, when you're diagnosed, basically we need to go to private doctors if you want real care.
Can I ask a question about that?
Sure.
When you go to the private doctor, so now you have to pay out of pocket
Mm-hmm.
at that
Yeah.
point? Do they have insurance of any form?
No.
It's all,
It's
if you want good treatment, you're gonna.
it's all out of your pocket. Yeah, no insurance there.
Interesting.
Go ahead.
When you go to the ER, how difficult is it to actually get diagnosed if you have a rare disease? I mean, in his case, it didn't sound like it was hard to get that diagnosis.
For me, it was a little bit easier than it usually is for the most of the people in Hungary because I already have other comorbidities, so autoimmune diseases. And based on my symptoms, they immediately suspected that it must be another autoimmune condition, and they immediately looked into WAHA. So they were very specifically looking for it. For me, it was easy. But with my other autoimmune conditions, it took a very long time, years, until they got diagnosed. Okay, let me pass.
Thank you. By way of disclosure, none of this information is from me. I had two colleagues, one hematologist from Nigeria, Dr. Onyinye, and a hematologist colleague, pediatric hematologist who deals specifically in inborn errors of immunity from India, who kindly shared their answers to some of these questions. So the pediatric hematologist from India says we have both government-sponsored and private healthcare in India. While hospitals run by the government are for everyone, the resources, especially high-end testing and medications, may not be available except in few centers of excellence. However, they serve as a basic and essential care providers, and private healthcare is predominantly cash-based, since only a very small percentage of people in India have access to private insurance coverage. The colleague, Dr. Onyinye from Nigeria, says healthcare in Nigeria, Africa, is primarily administered through a combination of private and public systems. The country does not have a fully socialized medicine system like some other countries. Instead, healthcare services are provided by government-owned facilities, private hospitals, clinics, faith-based health facilities. Healthcare financing in Nigeria is mainly out of pocket, with its catastrophic financial implications. The National Health Insurance Scheme, a social health insurance program designed by the federal government of Nigeria to complement sources of healthcare financing and to improve access to healthcare for a majority of Nigerians, so far covers those in the formal sector of employment and does not include all health services and drugs in its coverage. The operation of third-party payer is negligible and applies mainly to employees in private and non-governmental organizations. It is important to note that access to quality healthcare in Nigeria can be limited, especially in rural areas, and there are efforts being made to improve healthcare infrastructure and expand access to essential services, but there are still significant challenges to overcome in order to achieve universal healthcare coverage for all Nigerians.
Do you have any?
I can talk about healthcare in US, which you guys are all familiar with, and I have to say, after listening to all of that, is God bless America, right? I think, and I happen to work in a very resource-poor area with very poor insurance, with most patients having governmental insurance, and they're able to get any care that they need. Actually, they're doing better than people with insurance. Pretty much prednisone is a very cheap medication, as you guys know. It's covered, costs pennies, very easy to get. The rituximab is approved for patients who have either severe disease, right? So hemoglobin less than 8 at presentation in the first-line setting, or Evans syndrome, or if you don't want somebody to be on prednisone for a long time. So long time is 6 months, because that's usually how long most patients with autoimmune hemolytic anemia remain on the steroids. And if you justify it like that to the insurance companies, most insurance companies will cover it. If you have pure Medicare, you may have about 20% copay, but that's really the main challenges that we have. And I am coming from an Eastern European country. My knowledge is not up to date, but there was socialized medicine, and for medication like rituximab, you basically would have to pay out of pocket, which is, as I'm sure you guys know, is thousands of dollars. So that's all right. Yeah.
When you talk about governmental health care in the U.S., do you mean that Medicaid,
Medicaid, Medicare.
and Obamacare?
And I guess Obamacare, yes.
Okay.
Yeah.
Obamacare really falls under commercial insurance. 'Cause it's-
Okay.
Oh, see, you know better than me. Thank you.
And I'll just speak really briefly about my experience. I have commercial insurance, fortunately, but the issue I ran into is I had to do prednisone first. So I sat in the hospital for a week and a half, failing prednisone and 9 blood transfusions before I could finally get Rituxan, and my hospital bill ended up being over $120,000. Fortunately, I owed $3,500 of that, but if I didn't have insurance, that could easily bankrupt somebody. So while we have great care here, we still have problems with our payer system. Because my doctor knew Rituxan would work really rapidly, and it did, but I had to wait. I lost a week of my life sitting in a hospital room, so. Was there another question?
I was just going to actually throw in for this, the governmental insurance, you would also add in the TRICARE and
Yes.
and VA, just for Pat's benefit.
Thanks.
So you two may not be able to answer this question, but do you happen to know what the prevalence of WAHA is in your country?
My hematologist says it's one of the rarest diseases, and he doesn't have many patients. I even tried to talk with my hematologist. Hey, maybe I can start like talking with your patients that has WAHA, and try to connect with them. And he's like, there's not many. Like, he can probably count with all his fingers how many there are under his care. So I don't know about the prevalence, but yeah, that gives me a signal.
Kind of the same. I was searching online for any data, but I couldn't find anything. I also asked my doctor, and he said I was his only patient with WAHA. And I also looked through the Hungarian autoimmunity Facebook groups to see if there was anyone else diagnosed with this condition, and no one ever told me that they were. So it must be really, really rare, and I'm not really sure about the exact data.
I mean, I can just say, so everybody in the hematologic literature cites one paper from like 2001 or something, and it is from US, and the prevalence is 17 per 100,000. And that's the number you're gonna hear from everybody, because just nobody else has done it over. But for example, for cold agglutinin disease, the prevalence actually does depend on the country. And there was a study done by Dr. Berenson, who is the maven of the cold agglutinin disease, and he found that in Northern European countries, the prevalence was much higher than in, let's say, Italy, and that was the comparison they used. And I don't remember all the numbers exactly, but it's, well, the cold agglutinin disease is probably like 1/3 as common as WAHA.
15% of the, to 85% is WAHA, 15 is CAD.
So the hematologist, pediatric hematologist from India says there is no nationwide single registry for AHA patients in India. Extrapolating the incidence in a Danish registry, a 2023 Lancet Southeast Asia article estimated that annually we will see about 25,000 new AHA cases in India. And mind you now, India has a population of about 7, 8 times that of the US. It is impossible to figure out how many of these are secondary to a lymphoproliferative disorder, and how many of them are primary autoimmune hemolytic anemias. And obviously, they don't separate the warms and the colds here. my Nigerian colleague says there is no national prevalence study of WAHA in Nigeria. However, a single center study in the University Hospital of Southern Nigeria revealed a prevalence of 1.68%, which is pretty high, but in patients with cancers, most commonly CLL. Another institutional study revealed a prevalence of 0.8%, that's also pretty high, in patients with HIV. So as you all know, secondary conditions in the US alone account for about 50% of cases. I would suspect that secondary WAHA is probably a lot more common in some of these countries because treatment for CLL or HIV may not be, as rigorous or as aggressive as some of the options we offer here potentially. She says, we also witness a few cases of primary idiopathic WAHA in practice, but a majority of these cases we witness in practice are secondary to non-Hodgkin's lymphoma, CLL, autoimmune conditions like lupus.
And I'll just add, I'd worked in oncology for 20 years when I was diagnosed, and I had never heard of WAHA. And for my provider, she's only treated 5 patients with it. So, and she's been in practice for at least a decade. So while we say it's like 17 per 100,000, I think that's so many more that have leukemia, and this is secondary and not as a primary. So there was a question.
Yeah. For Imola and William, do you feel that the lack of numbers has to do with the healthcare system and the fact that there is a requirement for private pay and that maybe patients are not getting diagnosed because they aren't going to the doctor?
Okay, so first of all, in Hungary, it's very, very difficult to diagnose an autoimmune disease. It doesn't really matter which kind, because first of all, I would say 40% of the population has the ability to go to a private doctor. In the public healthcare, otherwise only life-threatening situations are now being handled since like 8 years now. So I think many people are suffering from even WAHA, but it's not life-threatening. They just feel fatigued. They don't know what it is, so they don't even go to the doctor. And general practitioners don't really have experience with autoimmune diseases, so they don't even refer them to any other doctors. So it's pretty difficult there. And even if it's diagnosed as an autoimmune condition, as let's say it's WAHA, the private doctors are not, they do not need to report this to the governmental databases. So they may not even get the data there.
So in Canada, it is actually quite easy to do a body check. We call it like your annual. So with WAHA, you're going to detect it with your CBC, right? Hemoglobin count. But I think the issue in Canada, or maybe the doctors in Canada, they're too overwhelmed. And I can only spend maybe at most 20 minutes with my hematologist. So there's no opportunity to really have discussions or talk. You're just going through numbers. You're just going through symptoms, what you're feeling, very quickly, very rapidly, and then, hey, I'm going to see you in 4 months. So there's no opportunity to really have these discussions that we're having right here. It takes time, and they don't have it, unfortunately. Yeah.
I think you bring up a very important point, I would say. I have had at least 10 plus referrals wherein patients, again, sort of fell prey to a similar system with very short times with their initial visits, ended up being treated with multiple rounds of just iron supplements, B12, folate, because nobody went beyond, well, yes, you're anemic. You're young and you're anemic, you must be iron deficient. Or you're a woman and you're anemic and you must be iron deficient, which we all know doesn't work, in fact. It does more damage than potentially than helping. And so that's the one thing I would, to this audience, obviously it doesn't, help that I'm saying this, but I do think it's important for physicians to be aware of.
When I was diagnosed, they thought I had a GI bleed. So they wanted to do a colonoscopy and an endoscopy, and I'm like, I'm certain I do not have a GI bleed.
That's right.
So are there any unique societal or cultural perceptions about autoimmune diseases in your countries?
I think the good thing about Canada is we're a very diverse country, just as diverse as the United States. So culturally, I don't think there's any, there's no, any negative disposition towards people with autoimmune conditions. Yeah, I've seen people with many different types of conditions, and they're not judged on that. So I wouldn't say so, not in Canada.
I would say that in Hungary, most of the people do not even know what an autoimmune disease is. So they don't have a negative perception about it because they are not aware that it even exists. If I take a look in my circle of friends and the people that I know, to whom I have explained what an autoimmune disease is and what WAHA is, they don't have any negative perception about it. So people are really acceptive about it, but very few know only about autoimmunity.
I mean, you guys probably know as much as I do, but I don't think there are any negative perceptions about autoimmune disease in the US, but I think it's also so rare that most people don't know about it.
All right, I'm seeing the audience reacting to this and people squirming, so obviously we've hit a note with something.
A negative perception, it is a misconception. So when I go out and in Florida, for example, and I am dressed really warmly, like wearing a coat, people judge and say to me, well, it's because you don't eat meat that you are so cold. Or because you're too skinny, so you have to gain weight. So it's a lot of misconceptions. And when I say no, it's a blood disorder. It's autoimmune, and the cold damages or destroys my red blood cells. They still don't get it. So it's not, is it judgmental? Is it it's misconception. They just don't get it.
I think where the judgment comes in is in our symptoms. We tend to lay, sit, all of that, because we have no other way to exist. And we're perceived as lazy.
I will say it's really hard to call in sick to work because they're like, you don't look sick. Well, I'm tired. What do you mean you're too tired to work? Especially when I was working remotely, you're too tired to stumble across to your computer? Yes, I am.
I would also add that what I see a lot with my patients with autoimmune diseases is that, in addition to everything that you've all just said, is that there is a misperception, to use your good word, that autoimmune diseases are caused by stress. Therefore, if you just stop being stressed, you will stop being sick. And while we know that stress contributes to illness, I'm going to talk about that a lot actually myself, it is an absolute misperception that stress caused your illness. And I think a lot of people think that. So they say, well, if you just sleep and maybe if you work a little less, you should be easy to do that, right? You'll get better. And I think that can be very damaging.
And maybe just adding one note here and connecting to what you just said, I think that there is a misconception, definitely, no negative connotation, unless your symptoms are affecting the life of others. As soon as it's affecting others, they are already like, oh, do you need to eat gluten-free? Gluten is a trigger. Oh, that's just a fashion trend now. So unless you are affecting others, I think they're working it out good, but when it's affecting them, they already have negative thoughts.
Yeah, my colleague from Nigeria didn't have anything to add. Colleague from India says autoimmune disorders are in general more common in females. And so the access to proper treatment may be a bit limited for them due to gender bias that exists in healthcare, in seeking healthcare in our population. The chronicity of the disease, as some of you mentioned as well as visible signs like jaundice, could all add to some stigma about the disease. And again, I assume that these are people who probably were missed being treated for a prolonged period of time. She, of course, specializes in patients who have inborn errors of immunity, Evans syndrome, more severe autoimmune hemolytic anemia. But I would say the gender bias certainly is something that I have seen in the low-income countries that I have worked in as well.
And I'll just add, I felt really different when COVID hit because I didn't know what would happen if I got COVID and it activated my immune system and my WAHA came back. The treatment they would give me would suppress my immune system and then I couldn't fight off the COVID. So I was paranoid about everything being sterilized, wearing a mask, all that, and definitely felt isolated by perceptions that I was making too big a deal of it. But that's just the world we live in. So moving along, so what was your experience like with diagnosis and treatment?
I think I touched upon it. It was mostly in the ER, and it was a hematologist on staff at the hospital. So he did, I think, a complete blood count, CBC. And then he did a Combs test that was warm. Warm positive. Basically, that was the diagnosis part. He very quick, I think within 1 or 2 days, he was certain it was, or 90% certain it was WAHA. He did do some additional tests to make sure it's not cancerous or some other things like that. But then after those were ruled out, he was very certain that it was WAHA. Sorry, what was the second part? Treatment?
Just what was the experience like with diagnosis and treatment?
Okay, so for the treatment side, prednisone was very bad for me.
Mm-hmm.
It was a terrible experience. I was on it for I think 6 months or more. I think I was on it even while doing Rituxan, but Rituxan didn't seem to have the desired effect on me. And then I did go into a partial remission for a couple months. Unfortunately, I then got COVID, and that was what Sean was talking about. It did reactivate for me, unfortunately. But because I feel like my hematologist was very busy, I was telling him that I was feeling unwell. My hemoglobin was low. He attributed it to like my low hemoglobin during my blood test as a consequence of COVID. So I was feeling quite bad for a few months, like 3-4 months, until like he noticed that something was wrong and he wanted to see me urgently. And that was when things started to change a little bit. So in Canada, there is called a ongoing requisition. So you can go in to get your blood tested whenever your doctor sees fit. So he gave me that to go every week to check my hemoglobin, and then he put me on Cellcept. And I responded very well to Cellcept the second time around. So that's what I'm currently on. And that's kind of my treatment journey thus far. Yeah.
What is Cellcept?
Mycophenolate.
Mycophenolate, yeah.
It's an immunosuppressant.
Immunosuppressant. But it probably, not probably, it definitely carries less side effects that we know of overall than prednisone, and is probably more targeted potentially than prednisone.
Yep, agree.
It's not a treatment for CAD stuff.
No, not that I know of.
Works more for T cells, I believe. So CAD is more of a B cell disorder.
So as for diagnosis, I was lucky to have a really quick diagnosis, although the way to treatment was much more difficult. The first time I went to ER, they suspected that it was WAHA. They made the test, and it turned out that yes, it was WAHA, but I was sent home. At that time, my hemoglobin levels were below 8, so I was feeling really, really unwell and really fatigued and could hardly walk home from the hospital. And the next morning, I had to go back to the hospital because I was not getting better, which was not a surprise. And then the hospital I went back to didn't have free beds, so I was sent to another hospital, then I was sent to another hospital. And then in the third hospital, when I was already like crying, I couldn't really I was not able to think because like you're so fatigued and you're so frustrated and you don't know what's going on and whatsoever. I was just finding the first doctor who was available, and I told her that you gotta treat me, you gotta do something. And she helped me. I was in hospital for a week. I immediately received steroids, a high dose of steroids, which helped me pretty quickly. I was on them for 9 months. Let's not talk about the side effects. I think we all know that they are brutal. I was really happy that after 9 months, I was able to taper down to 0 milligrams. And this was 3 years ago. Ever since I'm in remission. But as for treatments, let me just add that, for example, Rituxan and biological therapy is not an option in my country. So it's a little bit more expensive than steroids. So in case the steroids do not work, they immediately do a splenectomy. And if even after a splenectomy you are hemolyzing, that's when they will consider that you can get biological therapy.
Wow, okay. So what do you think went really well and what didn't go well?
What went well was that my hematologist was knowledgeable in this space. I can't thank him enough. Like, to diagnose me this quickly and to put me on a treatment regimen that made sense. And looking through the WAHA group, like I was so happy to see that everyone kind of went through the same steps that I did. But what didn't go well is a problem with the Canadian healthcare system. We have a lack of doctors. It is a socialized healthcare system. Our doctors that we get trained in Canada usually come to the States because the pay is much better here. Unfortunately, the doctors in Canada are paid a fraction of what the doctors here in the States get paid. And it's very easy to cross that border, right? Just go to Niagara Falls, right? Yeah, just for the salary, right? And that's not going well. And I can't fault my hematologist for this, really, but because it's just a problem with our political system. We should have more funding for doctors, match the pay with U.S. doctors, get people to come to Canada that are specialized in hematology. Yeah, go ahead.
Patients from Canada cross the border to get treatment?
I haven't really looked into it, but I feel like I will have to pay an exorbitant amount of money to do so. I don't think my insurance company would allow that. I think it's called like travel for medical care, which is very frowned upon by insurance companies. It's like, you're not supposed to be doing that. Yeah.
There's a question over on the...
Sure.
Drug companies offer any kind of help for that kind of problem, someone to supplement or anything, like Zeno or Rituxan?
We have drug companies in the room. Does anyone want to answer that?
I'm not from a drug company. I'm a patient of CAD. But I talked about it last year that you have to be your own advocate to seek out these sources that are for you to help you. And these companies do. So like Genentech, I know, you have to fall into certain financial salary ranges. But I know, even like I talked last year with Johnson & Johnson and Imbruvica, it was $14,000 a month for 28 pills, but you had to make less than $109,000. So, it can fit for a lot of patients.
And I know JMO has the financial assistance for the co-pays, Medicare, that you do have to pay, you know, the 20%. So, yeah, it's out there, but you just have to find it.
Jim has.
I was just going to say, there's also the assistance fund for CAD patients that will help. The assistance fund has a patient assistance program for CAD patients where they'll help pay the out-of-pocket expenses for the Medicare population. And I think I'm not sure if they'll do commercial insurance too, but I know it's for the Medicare. So, but I just want to make sure that people knew that.
I have to say with our patients in JMO from Sanofi is Sanofi saved patients' lives because they were on transfusions, and that's a bad thing to have constant transfusions. And they have a program that we don't have rich people in our group, and their patient assistance program has been wonderful. It's talked about a lot.
So I'm from Sanofi. I work on the NJMO marketing team, so I can speak to this a little bit. We do offer a patient support program. We have a copay program and patient assistance. We have case managers who can help you figure out, you know, how to submit a prior authorization and how to work through with your insurance. And then we have TEMs like Jude, who spoke yesterday, who provide additional education. It's a really great program. Unfortunately, it seems like a lot of people just don't know about it yet, so we'll work on that.
Yeah, I'm Canadian, and as long as I get my treatment in Toronto, I don't pay for it. But I would like to go on in JMO, and I spend my winters in Florida. So I cannot go to a U.S. hospital. It would cost me a fortune. The only insurance that we have is emergency medical. So I could have a heart attack and I'd be covered, but this is pre-existing. So it is not covered. So that's why I'm going to reach out after this weekend and find out if there is any assistance that I could get while living in Florida.
I was just going to add, this is Christy from J&J, and I will just maybe speak at a broad level, which is, to your point, pharma companies want to help, you know, and they want to help, especially depending on your insurance, your country, right? Every country has different regulations about where pharmaceutical companies are allowed to help, and unfortunately, sometimes that's a frustration that we face. Is we want to provide that support, and depending on if you have government insurance, they have rules, you know, about what you're able to provide if you have private insurance. So I would just say that, you know, we are there to help, but you have to find us, right? And it is about knowledge, and that's actually where, as this type of organization is so phenomenal, to help spread that awareness and make sure you know what those resources are, and also helpful for us from a feedback perspective to hear, especially in some of these countries where there are challenges, you know, we try to bring that back and work on those and figure out, are there ways that we are able to help? So I would say that the short answer is yes. Regulations and rules in different countries all have various challenges, but we are here to help wherever we can.
I just wanted to say, in my case, I had Rituxan treatment one time for the 4 sessions. And to make the point that my hematologist office, the financial part of his office, once they found out that I couldn't afford the incredible cost, did all the paperwork. And I just want to make that point, that you might want to really consider discussing that with your hematologist or whomever, their office. It was pretty, obviously for me, it was very seamless, and when you're not feeling well, of course, you don't want to have to deal with anything more than you do. So put that point out there.
So
So Nina with Johnson & Johnson, and I am the Director of Policy and Advocacy. And so one of the things I'll add is in the U.S., as you try to get medication, part of the challenge is even when pharma companies do offer copay cards or some sort of financial assistance, the way the system works in the U.S. is payers, insurance companies, will come in and tell, say you, the end user cannot use that copay card, or it won't count towards your deductible or your out-of-pocket, right? And so that's not a product of the pharmaceutical company. It is a product of the insurance or the insurance plan that you are utilizing. And so it can happen on, if you have Medicaid Advantage, it can happen on those plans, it can happen on commercial plans. And so there's just a lot of ways in the system currently where they can maneuver you, the patient, not being able to access the copay card, which drives up your out-of-pocket cost. So my one pitch, advocate for yourselves, right? When those things come up, when policies come up in your state, just become aware of them and share your stories, because that's what really helps to get the legislation changed.
Sorry, I just want to quickly add that, in some of my refractory AHA patients, I have prescribed fostamatinib based on a trial. It's not FDA approved for WAHA, but based on a phase 3 trial that Dr. M was part of as well. There is data suggesting that there is about a 40-ish% response in WAHA patients. And I want to bring this up because I know that the company, at least in some of my patients, offers about a 2-month supply just to see if it works, and then you can decide if you want to continue it or not. Now, it's not without side effects. There are GI toxicities. You have to monitor your blood pressure closely and so forth. But I do think it has helped quite a few of my patients.
So, actually,
I want to make a quick pitch. Sorry. Remember that clinical trials are free if you don't have insurance, right? So one way of getting the medication, if you have no access to it and you need a change, is to consider a clinical trial. So.
The only other thing I'll add is I'm an oncology social worker by training, so I work with patients. And early in my career, I did a lot of work with unfunded, uninsured patients and filling out hundreds of patient assistance forms. And there is a lot of help out there, but there were changes to Medicare that happened probably about 10 years ago that really limits what drug companies can do to support patients. It prohibits someone from Medicare getting certain types of assistance. So that really threw a wrench into our system. So there were a lot of people that were then excluded from that care. But what has happened is there's nonprofit organizations, I can say the Patient Advocate Foundation, Health Well, that they have pockets of money that can then also help with co-pays and even sometimes travel expenses if you're having to travel a distance for your treatment. So unfortunately, we have run out of time, and I didn't even get through half my questions. So thank you all very much for sharing your experiences.